Welcome to the APFCB webinar on the role of clinical laboratories in COVID-19. In this lecture, Dr. Julai Kumalavati will be talking on the serological testing for COVID-19. Dr. Julai Kumalavati was graduated as a medical doctor and later received her diploma in medical microbiology and earned her infectious disease consultant degree from the Indonesian Clinical Pathologist Collegium in 1996. She is currently lecturer and the research coordinator at the Clinical Pathology Department of Medical Facility Universitas Indonesia and Dr. Kipto Mangunkusumo Hospital in Indonesia. She has served as the president of Indonesian Association for Clinical Chemistry from 2013 to 2019 and a chair of Professional Issue Committee of Indonesian Society of Chemical Pathology and Laboratory Medicine.
For the serological testing of COVID-19, I will talk about the test indications, about the seroconversions of SARS-CoV-2 infections, and the possibility of anti-SARS-CoV-2 and SARS-CoV-2 antigen detection usage. As all we know, if somebody got infected, the typical seroconversion will start with the development of or the detection of IgM class antibody followed by IgG class antibody. If there is a reinfection in that person, then IgM will still appears but lower with lower concentration compared to the primary infections, but IgG will be detected faster and with higher concentration during or after the secondary infection. But how about in SARS-CoV-2? There are some certain patterns that is not typical seroconversions compared to other infectious disease has happened in the patients with COVID-19. As we know, serological tests, we can either detect the antibodies or the antigen. It depends on which stage or phase of the patient that are tested. Uh, so whether we can use the antibody or we can use the antigen. As we all know, we usually test a person to diagnose the person, either for early diagnosis or for confirmatory diagnosis to to determine the patient management during the disease. But we also need to diagnose the patient to determine the safety level of the healthcare personnel that will care for the patients. So either it's for triage, whether or patient management, or determining the healthcare safety level. But besides diagnosis, we can use also serological tests for surveillance purposes, for instance, to know the epidemiological burden in certain area and which preventive measures that we need to implement in those areas. I will start with the seroconversion in patients with COVID-19. There are several researches that has been published to show that different patterns of seroconversion of antibodies can be found in patients with COVID-19. This slide shows research from Germany following up 9 patients. The red arrow indicates the time that the antibodies, either IgG or IgM, to SARS-CoV-2 are started to be detected in those patients. As you see, most of the patients here, of the 9 patients that they follow up, the antibodies will start to be detected around day 6 to day 12 after the onset of symptoms. As that pattern is the same as this graph that published by Chinese in the Chinese researchers. As you see, you can see that antibodies can be detected starting on day 7 or to day 9. And as you can see, both IgG and IgM class antibodies to SARS-CoV-2 appears almost at the same moment. There's also another research showing that uh, different levels of antibodies according to the severity of the symptoms. The red lines is uh, representing the severe symptoms, uh, patient with the severe symptoms. As for the black and the green graphs are from the patients with mild symptoms. As you see, the level of antibodies are much higher in patients with severe symptoms compared to the mild ones. Another research from China, they presented the seroconversion of antibodies to SARS-CoV-2 into 3 different patterns. Pattern A shows that there is a synchronous detection of IgM and IgG antibodies to SARS-CoV-2. So IgG and IgM can be detected and started to be detected at the same time. Pattern B is IgM can be detected earlier than IgG. But there is another type C, another pattern, in which IgG can be detected earlier than IgM. So, with all those researches, we are now more confused on how the pattern of seroconversion in COVID-19 patients can develop. So, after so many researchers, there's one researcher that trying to compile all the data from other researchers and put them into a graph. As you see, the blue and the red graphs represent the results of the PCR and the virus isolation from the respiratory tract of patients with COVID-19. As for the test graph, either the green one or the purple, depicted the antibody or from the class IgM and IgG against SARS-CoV-2 virus. As you see, antibodies also came late in this graph. Only after week 1, then we can start to detect IgG or IgM antibodies to SARS-CoV-2. So from this graph, we can conclude that antibodies cannot be used for early diagnosis of COVID-19 in patients. Only after week 1 of the onset of symptoms, we can start to detect the antibodies. There's another research from China which trying to detect also IgA class antibodies to SARS-CoV-2. It looks like all these antibodies appears almost at the same time, yeah, around day 5 to day 3 to day 5 after the onset of infection in this research. So there is one, after all those data that we can see, we know that antibody detection can be used only after days 5 to day 7 of the onset of the symptoms. So if we test using the POCT test to detect antibodies for screening of patients, it can be misleading to all of us. Yeah. In this letter to the editors, it stated that testing for antibodies using POCT cannot replace the PCR. So we need to be careful in using antibodies for early detection because it could lead to uh, it could mislead us uh, to diagnose or to determine the status of a patient as negative, although the patient is to uh, infected by SARS-CoV-2. There are several myths that is going on in the world. Different areas has different myths about the SARS-CoV-2 antibodies testing. In USA, they test because they feel that if they have antibodies, they are immune to SARS-CoV-2. But in other places, like Indonesia, where I came from, so a lot of healthcare workers and a lot of primary healthcare facilities use antibody testing to early detect the infections of SARS-CoV-2. So there's a still big question mark whether if if it's positive, if it's still active infection, or if it's negative, there is no infection of SARS-CoV-2. So we have to be really be careful about this antibody test. So from all that researches, from all that reports from journals, I concluded that antibodies to SARS-CoV-2 can be tested for contact tracing of COVID-19 patient, yeah, especially after day 15. Yeah. For instance, if a patient is positive and got admitted for COVID-19, we can test the family members uh, for antibodies to detect whether they have been exposed to the SARS-CoV-2 or not, but not to diagnose these family members whether they are really uh, infected or still infected by SARS-CoV-2. We can also do contact tracing for healthcare personnel that has been exposed to COVID-19 patients uh, after day 15, the contact, but not before day 15. We can use also antibody testing for to determine the epidemiological burden and the progression of this infection in the population, but we need to do it periodically in healthcare facilities and communities or certain communities. So, for instance, once a month or once every 2 months to know whether there's an increase of exposed uh, persons to SARS-CoV-2. Now I will start talking or presenting about the SARS-CoV-2 antigen detection. From this graph, we can see that detection of antigen is possible during the early infection, even before the onset of the symptoms. Because as you see that virus isolation can be uh, positive during that period. So if there is a virus there, usually we can detect the antigen. As we know, SARS-CoV-2 has different types of antigen. We have the spike, the S. We have the envelope, the E antigen, and we have the N antigen, the nucleocapsid antigen. So these three antigens can be used for detection of SARS-CoV-2 in the respiratory tract. But of course, antigen detection has their own drawbacks. This graph shows you that antigen mostly can be detected if the viral load is high enough. If the viral load is very low, then we can miss the, the detection of SARS-CoV-2 using the antigen test. Yeah. Only those with low CTs, which means higher viral load, can be tested with antigen detection. There's another research also, as you can see uh, in this graph, the same result only with the circle to threshold PCR results that is low, then antigen can be detected. So the possibilities of detection of, sorry, there's a misspell, of SARS-CoV-2 antigen can be used as an adjunct to nucleic acid tests for early diagnosis of SARS-CoV-2 infection. But we have to remember that good sensitivity is only for specimens with high viral load. So we need to do some validation or verification of antigen detection reagents prior to the use in the healthcare setting. And we still have to remember that since for antigen detection, we still need to collect nasopharyngeal swab, which is potentially infectious. So safety precautions for this antigen test must be the same as for nucleic acid test. So although there is some rapid tests available, these rapid tests cannot be used in an open air uh, environment. We need to use biosafety level at least 2 to do the antigen testing, even if we are using the rapid test. So my closing message are antibodies to SARS-CoV-2 will develop late after the onset of symptoms. Therefore, it's only useful for surveillance purposes, not for early diagnosis. For antigen testing, the reagents that are available now can only detect antigens in patients with high viral load. So we need to do validation of verifications of reagents to detect both antibodies and antigens to SARS-CoV-2 prior to usage. Thank you for your kind attention. I hope this knowledge will be useful for all of us.